Hi, good afternoon, everyone. Welcome to our Facebook Live for Friday. Today, we want to discuss about navigating your way through post-acute care, IRF versus SNF. I want to introduce quickly to myself. I'm TJ Patel. I'm founder of HOMECARE2GO.com. We are a mobile technology platform. We are simplifying care at home. We have a mobile application and website where anybody can find any available care options around them. We are active in 5 states and happy to have any company providing any kind of care in these 5 states, that is Arizona, Florida, Michigan, Texas, and Idaho. Just go ahead and contact us. We can list your company so anybody can find you online for their loved ones or any kind of healthcare professional. If they're looking for resource, they would like to get your information. That being said, I want to introduce my co-host, Michelle.
Hi, everybody. Hey, I'm Michelle Campobasso. I am the physician navigator for post-acute care in Allen, Texas. I actually work in the secondary markets. So I work in the skilled nursing facilities, assisted living, home health, home care, and independent living. I actually have a great market. I get to work in all of the assisted living, so I get to see everybody and kind of work with the home health and home care that way, with everyone being impacted with COVID. So it's been a great experience for me. I would like to do a little bit of an introduction with the rest of the staff that I work with at PAM. We have Dr. Ivan Figueroa, who is our medical director.
Hello, everyone.
We have Mr. Yes, hi, Dr. Fig. And then we have.
Oh, we're all popping up.
We have Mr.
Hello, everybody.
Shayne, who is the regional vice president of strategic initiatives, and then we've got Mrs. Pam, and I can't say your last name because I'm horrible.
Kneuper.
It's Kneuper.
Kneuper, okay. The Vice President of Strategic Initiatives and Integration. So thank you, everyone, for taking your lunch break to be with us today. We greatly appreciate it. Today, we are going to be talking about the navigation your way through post-acute care. And TJ is going to start off with the questions to, I think, Shayne. So you're on camera.
Yeah, why don't all guests just introduce themselves? So you want to get started, Dr. Fig?
Okay, I'll go at it. So my name is Ivan Figueroa. I'm a physical medicine rehab physician here in Allen, Texas. I'm the medical director for the rehab hospital for PAM, post-acute medical here in Allen, Texas. I don't know how long I've been around. I think 12 years or so. And I'm happy to be here and be able to answer any questions anyone might have.
My name is Shayne Goode, and I'm the Regional Vice President of Strategic Initiatives for PAM. I've been with this company over 10 years, and I've kind of come up through the ranks. I actually started out as a clinical navigator out in the field, trying to qualify patients for our different levels of care, and then I was promoted to be a director of strategic initiatives. I spent 4 years as the CEO of our long-term acute care hospital in New Braunfels, and now I'm in this role. So I'm just trying to, these are, new times for us, and just trying to learn how to navigate through the pandemic and how we can help. It's just interesting. And I will pass it over to Pam Kneuper, and she can introduce herself.
Good afternoon, everybody. My name is Pamela Kneuper. I'm the Vice President of Strategic Initiatives and Integration for Post-Acute Medical. I have been with this company since 2011, and like Shayne, continue to work every day on strategies across all of our hospitals that we serve and the communities that we serve. Post-acute medical, just a little bit about our company, is located in 12 states. We have 42 hospitals, inpatient facilities across 42 states. That's inpatient rehab hospitals and long-term acute care hospitals. Our corporate office is based in Enola, Pennsylvania. And our mission at Post-Acute Medical is to provide high-quality patient care and outstanding customer service, coupled with loyal, dedicated, and highly trained staff to be the most trusted source for post-acute services in every community we serve.
That is so exciting that, you know, like all of you are taking time and talking to us and making all the viewers aware about what's going on with PAM and all the initiatives. So I have first question with you, Ms. Pam. So I have heard you guys are having a COVID clear protocol. So can you share with us what is COVID clear, what it is consist of, and how normal person can make sense out of it?
Sure. In response to the coronavirus, we are dedicated to assisting our communities. With that, we've developed a COVID Clear program that is for our inpatient rehab hospitals. This program is for patients who tested positive at one time for the coronavirus or COVID, and now have either had the admission criteria is they've had one negative COVID test or 3 days have passed since recovery, defined as resolution of fever without the use of fever reducing medications. They also have to have documented significant improvement in respiratory symptoms and at least 7 days that have passed since their first symptoms have appeared. With the COVID Clear program internally, the program includes patients are admitted into a room that is on a COVID Clear designated unit. These are private rooms. All patients are placed in droplet precautions for at least 72 hours from the day of admission, just so we can monitor their temperatures and their respiratory symptoms and to really make sure that they are truly negative at this time. Therapies are provided in the room or a designated unit or in a modified gym. Therapies are provided as tolerated by patient and ordered by physicians. If the patient needs to leave the room, we will have surgical masks placed provided by our hospital. And we do, because we are not allowing visitors at this time, we are making sure that our families can visit with patients. So we're making a concerted effort to include patients and family members and their family members on their education and their therapies. We're doing a lot of phone calls with the nurses and the patients' families, as well as our physicians. But we're also incorporating FaceTime into this, so patients and their family members can visit via FaceTime and have some live connection with their loved ones. So that is our COVID Clear program for our inpatient rehab hospitals.
So I have a follow-up question on that. So so that is one-on-one care in patient's
Correct.
room, and like let's say whatever patient can tolerate. So there is nothing like 3-hour minimum, 2-hour minimum, nothing like that, right?
Not at this time. So, you know, CMS, and we'll talk about waivers a little bit later, but we do, CMS, if it's related to the COVID emergency, we do have a 3-hour waiver. So what we're going to do, if patient can't tolerate 3 hours of therapy, we're going to provide them the therapy that they can tolerate and work them up. As they can tolerate more, we'll increase their therapies.
Okay, so that is good to know, because like let's say somebody like me, I always used to assume that okay, inpatient rehab means 3 hours of therapy. If a patient is not able to tolerate 3 hours of therapy, in plain vanilla language, they are not going to be qualified. So let's just not focus on sending them to inpatient rehab and maybe look for other options. So in today's situation, it is not 3-hour minimum. It can be whatever patient can tolerate.
As long as it is related to the COVID
emergency.
And the waiver, it states that in the waiver, and we have to have the documentation in the chart.
Okay.
And that's all behind the scenes. You know, if anybody has any questions about that, the best thing to do is reach out, let us do an assessment, an on-site evaluation, and we can make that determination on the back end. We do these things very quickly. We pride ourselves in having a 2-hour turnaround from start to finish. So we expedite these things. So if anybody is even on the fence about whether or not they have, you know, their patient or family member is a good candidate for our facility, they just need to give us a quick call and we will be right out to take a look.
Sure. So I had a question for Dr. Fig. So you being the medical director with PAM Hospital in Allen, would you share with us what's the ongoing situation under the current pandemic and what are the clinical programs you are leading in Allen Hospital?
Well, yeah, okay, thank you. There's two different, I guess, parts to that question. With the first part, I mean, to tell you the truth, we're still kind of adapting. Some of the things that we noticed is what we just talked about. So we have some different waivers ongoing right now that are changing how we decide which patients can come in and where we can provide services to them, like the 3-hour waiver, among other issues. So it's been different for sure. It's actually the market itself has been kind of slow with the coronavirus pandemic. It sounds like people are staying away from the hospital for the most part. So that's something that I'm kind of curious about how it's all going to act or finish up in, say, 2 to 3 weeks when people do start coming back to the hospitals, and how crazy that's going to be, for lack of a better term. So I'm kind of curious to see how that all's going to go down right now. So other than that, I mean, to tell the truth, I don't see a huge change with what we're doing here. Even those patients that we were talking about right now with the 3-hour waiver and all that, the patients that we have admitted, we are treating them like acute inpatient rehab patients. We're still doing the therapy and all of that. We're still trying to get them as much therapy as they can, because that's what we do. That's what we're good at, is keeping people moving and getting them stronger and getting their mobility back and independence so they can get home. And from my standpoint, the best way to do that is get them as much therapy as they can. So we're still pushing for that. Don't get me wrong. With regards to specialty programs that we have here at PAM, we have 2 certified specialty programs through JCO, or the Joint Commission. One is the stroke program. We've had that, I don't know for how many years, but at least probably 4 or 5 years. I might misspeaking, but it's been a while. And then we also have a brain injury rehab program. Both programs, there's nothing that the patients have to do or referral sources or all that. It's just we have a whole protocol, a whole team that has developed this program. When the patient gets admitted, then we have to follow certain criteria and make sure that we're providing certain education to the patients. We have specialized therapists that work with brain injury patients, strokes, and so forth, that take over those cases. And most of it's a lot of education from everyone involved, all the way from pharmacy, dietitian, neuropsychologist. Everyone provides a significant amount of education for a patient who's been through either strokes or brain injury. We're also going through certification pretty soon for Parkinson's, but obviously with the whole COVID-19 thing, that's kind of on hold. But that's basically it for the specialty programs here at PAM.
So to just make it clear, anybody with any kind of neurological condition, stroke, any kind of brain injury, they should not be holding themselves, not getting the rehab. You guys are COVID clear. You guys are ready to go, business as usual, taking extra precautions, not letting any kind of like cross contamination opportunity arising.
No. Everything we can. We do have special precautions that we don't have visitors. We're still doing the temperature checks for everyone, including all the physicians, myself, or anyone else that comes in. There's restrictions on vendors and can come in. So we're doing everything we can to avoid any sort of coronavirus incident here in the facility. Obviously, staff using masks, all the cleaning hands, everything we can. So we should be fine. I mean, from that standpoint, I don't think that should be a problem. And I will tell people, if you have the need and you need rehab, then it should be perfectly safe. Obviously, things happen, but I don't have any major concerns. And we have been getting a little bit more. It's been picking up, so people are kind of coming around. I guess we're getting people from home and all that. So as we move forward, we're learning more about this process and how to take all the necessary precautions. So me personally and our staff, we feel much more comfortable. We have the COVID clear unit, like we've mentioned. We've been doing that now, I think, over a week and a half. And so far, I think the results have been really good. So, again, we're getting more comfortable with that. And, we're good to go.
That is so encouraging to see. And like, let's say I just want every user to make a note of that, that, you know, there is nothing to hold back to. If you need rehab, if your doctors are asking you to get rehab, go ahead and call them, check and see what they can do. And then how long typical one admission lasts in your hospital? Like how much duration is the typical stay in your hospital?
The average length of stay is about 11 days, but we obviously have a wide range of patients that we admit. So there are some patients that are going to have, 8 to 9 days stay, and strokes, especially those that have significant neurological deficit or brain injuries, the critical ill patient that's been in the ICU, they have still have tracheostomies and all that are much sicker. Some of them stay here 3 weeks, even longer. So it depends. There's a lot that goes into that, but once they come in, we do our evaluation. Me, the therapist, the nursing, all that information goes, and we use that information to determine how long the patient needs to be here. It's 11 days. It varies.
So that is fairly short-term stay. So 11 days is, pretty much 2 working weeks. So
Yeah.
so like, let's say that should not be a long time for anybody's consideration, especially when they have acute care need.
Yeah, it's a short stay for the most part. Again, with some exception, maybe 20 days is a little bit longer. But yeah, most of the time we're gonna get people here. We're gonna go at it immediately, and we're gonna work on actually getting you home. The time you enter the facility, we're already talking about discharge plans and how we're gonna get you home, and calling you guys to help us out with whatever needs they have after their stay here. That happens immediately. Actually, we discussed it when I get the referral. I'm already thinking about plans and all that. So yeah, the system, that's how it is. We don't get a whole bunch of time. We got to get people better quickly and get them home.
Okay, great. So I would like to get Mr. Shayne, and I have a question for you. So the question that I have is, if you can give us a 30,000 feet high view, the difference between, like, let's say, I'm just asking on a point view of a general public. I know some difference. Maybe I will take this opportunity to learn more. What is the key difference between IRF and SNF?
Well, I think the main difference is that the IRF it's a hospital, so that is the biggest distinction. So if you're looking at physician oversight, it has to be daily. If you're looking at the nursing intensity, it's much more significant. The nursing care is about 1 to 5, 1 to 6, maybe, in the skilled facility. I apologize, in the IRF versus it's much, they have several more patients in the SNF. Also the therapy intensity, it's one-on-one therapy, group is not done. So the therapy, whether it's occupational, speech, physical therapy, it's all done one-on-one. Like we said, typically it's done, it's 3 hours a day. It can be stretched out over 15 hours over 7 days. It just has to be 900 minutes in a week. But right now with the waiver, we aren't required to do that. We can start out with as little as 1 hour and then build up gradually. So like Dr. Fig had said, they bring them in, and so far it doesn't look like it's been a problem. But if it is a problem, we don't have to meet that requirement, and they have continued stay criteria with the waiver in place right now. The other thing is we have the specialists that we have. So you have pulmonary, cardiology, you have nephrology. The dialysis is done in-house. We don't have to worry about sending them out. So just the complexity of the cases that we see in the IRF is much more significant than what they're going to see in a SNF.
So the complexity of the patients that you are servicing, that is more acute. And as Dr. Fig mentioned, that it is typically 10 to typically 11 days.
That does vary. So some of them may come in and they say as little as 7 days. So you may have somebody who has like a CHF exacerbation. So they come in and they still have some medical needs. So maybe they still need a little more Lasix and they're still drying out. And then we really focus on what we can do for them physically, really try to get their function back. So we'll have physical therapy is going to work on mobility, getting them up and moving. Occupational therapy is going to work with them on like their ADLs, ADL endurance, and just get them where they're independent so they can go home and stay home. And there's not a risk of readmission to the hospital. The more complex it is, like you said, yeah, they're going to stay longer. So if you have someone that has had been in the ICU. Maybe they suffered respiratory failure and they were on a ventilator, and now they're off the vent, but they're still trach. So we're going to get them out, get them up, look at early mobility, get them moving again. What can they do? Look at, making sure we're monitoring their respiratory status, in that particular facility in Allen, they have 24/7 respiratory therapists. So if they require like frequent suctioning, if they require neb treatments, even if they require a little bit of like nocturnal ventilation that's life support, but they're only going to need it at night, but the respiratory therapists are there so they can provide it. Ultimately, they want to decannulate that patient, get them walking, get them as functional as they possibly can, and hopefully discharge home. Sometimes in those cases, that may be a disposition to SNF. So, that's where we work with, while we're talking about the differentiation, there are times that we can't get them home. So we have to be able to work with our downstream providers. And if it's a skilled facility, we need to make sure that skilled facility has the services that this particular individual is going to need. So it's really important for case management to know what these skilled facilities have to offer so we can marry that particular patient to the right downstream provider.
Yes,
and the same thing is true if the patient goes home. We got to make sure that the downstream provider, which then would be a home health, can provide those services as well.
Yes, and you are so right. Like, let's say sometimes if case managers are having little more time and access to more information, I think they should be able to make a clear recommendation to the patient or their family, where on setups like PAM Hospital, they will be able to get all this specialty, more acute level, intense rehab related care all at one spot. And sometimes it is difficult to achieve in some SNF. Like some SNF has more services than some other SNFs, but I think with post-acute medical, I think the value that you guys are bringing is bringing all specialty level acute care with intense rehab all at one spot.
Right. One more time, the biggest differentiation is the inpatient rehab. It's a hospital. It is a hospital. It is not a skilled nursing facility. It is a hospital.
Okay. Michelle, you had a question for Miss Pam. Would you go ahead and ask that question for Miss Pam?
Yeah, absolutely. So Pam, we've been hearing a lot about the waivers, and we would just like for you to be able to talk to a range of people who are actually interested in knowing about when they hear the word waiver. Can you elaborate on the current Medicare and private insurance waivers, if there's what's going on with them, and how can people find out about them, and can you educate even my core audience, which are family members, to know about what's going on with those?
Sure. So in response to the pandemic, our private insurance companies have issued waivers for pre-op. So if your family member or loved one, or if you're a potential patient or referral source has a patient with private insurance, many of those companies have waived that authorization as long as they meet inpatient rehab criteria or inpatient LTAC criteria. They still must meet criteria, which obviously that's our job to figure out if they meet criteria, but they have waived pre-auth. So it makes it's basically an expedited admission. We can admit those patients most times the same day. So that's on the private insurance side. As far as CMS, in response to the pandemic, CMS has provided both the LTAC and the rehabs with several waivers. These waivers are in direct response to the COVID emergency. So if this is a patient in a hospital or a patient in a skilled nursing facility or an assisted living or an independent living, if this is an admission due to the COVID emergency, these are the waivers that we have. On the LTAC side, that 3-day ICU waiver has been implemented, which means those patients no longer have to have 3 midnights in an ICU or step-down unit. They've also waived the 25-day length of stay for the LTACs. So they no longer have to meet that 25-day length of stay. And then on the rehab side, which is obviously your facility in Allen, we have the 3-hour therapy rule release. So that allows us really the opportunity to take some of these patients that may be too low level or medically complex that traditionally we maybe wouldn't have taken a couple of weeks ago because they could not meet that 3-hour minimum therapy requirement. And then we also have the 60% compliance waiver in place. And again, that allows us to take more patients that are not in that CMS 13 category. Your CHF exacerbations, your COPDs, your UTIs, your falls, your debility patients that are just declining in the SNF, in the ALs, in the ILs, or even at home. So that's really where we're seeing an increase in our volume as well, especially in your market. As you know, you guys have a lot of SNFs in your area, a lot of ALs, a lot of ILs. It just provides us an opportunity to partner with those facilities, bring their patients in or the residents in, provide them with the therapy they need to get strong enough to be able to go back home and be a healthy resident.
Absolutely. I think that that's amazing. And especially in the secondary market, I'm definitely seeing that more and more. We definitely can partner with all of those entities. And I know that even with the home cares that they're doing home assessments. So if the hospitals are pushing them out, I am getting the phone calls from the home care and the home health that are saying, hey, we still need to look at this patient. So it's been an amazing transition from one facility to our hospital.
Right.
Absolutely.
I would like to
TJ?
add, I would like to add on that, let's say a lot of facilities that we servicing patients, especially senior living facility, assisted living and memory care facilities, where there is less interactions with the patient. Like let's say it is just a little difficult for a lot of companies. Either patients are voluntarily requesting the discharge or maybe putting the services on hold. And what happens is it complicates things, and then they end up getting declined in matter of 1 or 2 weeks. And then it is very challenging for the home health care to put all the resources together. So I think for that Goldilocks situation, I think they should be considering post-acute medical hospital, get that patient, get the intense care, get that patient stabilized, and then transition out to home health care, and then home health care can provide more routine, ongoing rehab and nursing care.
Right.
So that is spot on. Yeah.
Yeah,
So,
and our goal with every patient is to get them back to their previous setting, and ultimately, we hope we are able to get every patient back to their home setting with their family and their loved ones, and to know that even during this pandemic, we are taking every precautions that we can to keep patients safe, to keep our staff members safe, our physicians safe. So we pride ourselves in the high quality of care that we're providing.
Absolutely.
okay, I had a question for Dr. Fig. So let me. So I've been hearing that let's say with this current relaxed waiver programs, let's say what are the typical, let's say, so you being medical doctor, what are the conditions any kind of case managers or discharge planner or any kind of senior living community leaders should be focused on, where let's say starting ranging from stroke and brain injury, everybody can understand that, but let's say CHF, some other chronic conditions, okay, what warrants some medical stabilization through institute like PAM, and when they should be considering, even for the chronic conditions, PAM hospital?
Yeah, there's pretty much most anything's on the table. Like Shayne said, we're a hospital, so I guess one thing that comes to mind is those patients that might be at home. Let's think about the people that are in community that be at home and they are having some medical difficulties, but we're not sure if they need to go to the hospital per se, or they have been to the hospital multiple times and they just keep bouncing back. Some of those patients might benefit from us looking at them because it might be a multifactorial problem, that it's all medical, but there's also the factor about, again, the lack of mobility at home and all that affects their health. So we can manage. I mean, the CHF, we have cardiology here. We have obviously me and the other PMR physicians, we round every day on the patients. We have internal medicine. We have multiple groups here. I have like 4 groups that are really good, all of them rounding every day on patients. We have nephrology. We have, I don't know how many groups from nephrology, I lose count, that are also very responsible. I keep an eye on their patients and help us manage fluid, manage renal function, make sure we're giving the right medicines all the time, while again, keeping people out of bed, keeping people moving around, improving their mobility and all that, which again, I am biased. I'm a rehab doctor, but I think that is great for their health. So, I mean, we can see everything. From home Parkinson's, multiple sclerosis, and all those neurological cases. A lot of patients that have fractures, maybe have a pelvic fracture. What else? I mean, you name it, everything. People that are having infections, and they might be elderly who already are fragile, and they get a simple infection, and that might be enough where it just throws them off, and they're not able to take care of themselves. They have ongoing medical issues, then we can definitely help them and hopefully get them back home and get them straight again, and hopefully stay home for a while. Also to avoid, again, readmissions and all that. So that's, I think, where we can come in and help out a whole bunch, actually.
Okay. So like, let's say that is very, very valuable piece of information. Like let's say, let me jump it into a question that is asked by one of our viewer here. April Davis is asking, how you all handling hospice referrals? We have seen hospitals waiting for PCPs, but PCPs are doing televisits. So you want to shed some light on that? Maybe answer that question.
I mean, from my sample, we haven't changed anything. I mean, this is hospice referral, home health referrals. We're doing the same thing. We're contacting the providers. I don't know that they're visiting the patient in-house. I think most of it is conducted via phone, and then we fax the information on all that. But I know, I mean, I sent actually a patient on hospice last week, and we were able to arrange it. So I don't know that we're doing anything else. Case management, still handling that. And if I determine and internal medicine determine that's what they need, then we'll talk to family. They're in agreement. We'll contact hospice company of choice and provide them all the information. I'm the one that ends up writing the orders and all that.
So yeah, I think that answers the question. So basically, whatever the patients need and whatever obligation you have to feel as a doctor in the facility, you will be happy to do that, right?
Even I'll give a separate example because there's a lot of doctors that are doing telemedicine, right? So say we had a patient who had brain surgery recently, because that's still happening. They failed, they had a subdural hematoma, needed emergent surgery, and they need follow-up. If the physician or the family are comfortable with the patient visiting the surgeon, we can do that. If not, we've also done telemedicine through here. So we are trying to adapt as much as we can so we can provide all the care that they still need in just different manners. So everyone's trying to be as flexible as we can, again, which keeping the safety and all the restrictions as much as we can.
Okay. So yeah, that is good to know. Shayne, I have a question from one of our
TJ, I can't hear you.
Okay, can you hear me now? Let me just display the question.
I hear you, yeah.
Okay.
Is it about the insurance? I can. Do you see it, Shayne?
I can't hear.
I'll answer.
Can you repeat, Doctor? Well, either that or Dr. Fig, just repeat the question because I can't hear you.
Yeah, they're asking about what insurance we accept.
We accept a variety of insurance. So any of the major insurances we'll accept: Humana, United, Aetna. The ones that actually have waivers, or the big ones that have waivers right now, are Aetna and United. Now those, like Pam alluded to earlier, have to meet criteria, but they don't require the pre-cert. So as long as the criteria is in place, with this pandemic going on, we can bring them in, like she said, typically the same day.
Okay, can you hear me?
Did that answer the question?
Yes. Can you hear me?
Now I can hear you.
Okay. Yeah, I needed to just get out and come back in. So yeah, so somebody was asking that question, and yeah, it is good to know that pretty much you are accepting all the insurances, and pretty much like Ms. Pam have mentioned, that there is a two-hour turnaround time for giving anybody a response if they're making an inquiry about possible admission at your hospital. So yeah, like let's say I am excited. I think you guys are prepared, and then just ready to help as many patients as possible, serving their needs. Let's just summarize. I'm not getting any new questions here, so I would like all the guests to kind of summarize and like let's say want to give us any instruction that we should make note of.
Well, in summary, we're here to help. We have a continuum. I mean, from LTAC to rehab. I mean, we can provide a broad range of services, and we want to really be a part of the communities that we serve. From the navigators in the field who are doing the assessment, to the people inside our hospitals who are actually providing the care, which are, that's the heart and soul of what we do, to our case managers who are doing the discharge planning and make sure that they're in the appropriate setting when they leave us.
I think from my standpoint too, we are we're in 12 states. We have 42 hospitals, inpatient, LTAC, and of course we have outpatient services too, which are we're utilizing telehealth in those outpatient arenas right now, which is great for the patients. But I would think that if you have any questions, you can reach out to us, myself or Shayne. Obviously, if you're in Allen, you can definitely reach out to Michelle. But you can also visit our website at postacutemedical.com. That will show you where our locations are. It will tell you a little bit about our company. Then it'll give you all of the contact numbers that you may need if you have a patient or a family member that you think we could provide great care for.
And I'll add from my standpoint, I'll speak a little bit about, again, kind of reinforce the whole coronavirus situation and all that, and how it's affected. So I'm thinking here about what we talked like 2 weeks ago or 4 weeks ago when this all started. It was pretty crazy even for us because it's all so new, and every hour it seemed that something new came up and so many changes, and everyone's scrambling acute care. We are trying to figure things out, and things did kind of slow down at that point. Since then, I would say for the past few weeks or so, we feel we're gathering much more information. We're getting a much better grasp of what's going on, and we've been able to adjust. And I think from our standpoint, things are normalizing, if that's a word. I don't know that there's a normal anymore, but we feel much more comfortable with what's going on, the situation, and we feel that we can definitely provide a safe environment for the patients that need to be here and all that. I will say that, I mean, I feel we're here at work than I would say grocery shopping, for example. So we're trying to avoid all that. But my point is here, I mean, we are taking every single precaution we can, and we're keeping track of everything, all the CDC recommendations, everything that's out there, we're keeping track of. So I feel pretty good about that, and I want the patients and everyone else to also feel comfortable with that. So that's what I was saying closing.
Yeah, thank you all so much for your time. It has been a very informative session. I think a lot of people will use this information to help their loved ones, especially people like case managers and social workers. They will be able to effectively make their patients aware about what are the possible choices that they have when it comes to post-acute rehab. So thank you so much for your time, and it has been a pleasure talking to you and getting answers for all these common questions. Thank you.
Thank you.
I would like to... So Michelle is not there. Hey, Michelle, you wanna briefly mention about, so it has been amazing session. I think I personally got answer for a lot of questions that my patients typically ask me. So you wanna go over, like, let's say who is coming up next on our next Friday live?
Of course. Thanks, TJ, so much. And thank you so much for hosting this. We have a great lineup next week. We have Christie's Senior Solutions that will be coming up. And we have our very own Marla Jones, who's our registered nurse with post-acute Allen. And then we are going to be talking with Joe from Acapella Home Care because we had some technical difficulties last week. So she'll be joining us this week, and hopefully she'll be talking about pajamas for seniors, because I know that she's got an event coming up. So I'd love to hear more about it.
Thank you, Michelle. Yeah, like, let's say, amazing to co-host this program, and thank you, Pam, for
Thanks,
making this
Stanley.
community awareness, and yeah,
Thanks,
like,
TJ.
let's say thank you to all of you. Thank you very much. Have a good day.
Thank you. Have a great day. Bye.
Thank you. Bye bye.